Yeah, you can.
Yeah. So on behalf of Tamil Nadu Science Forum, I'm welcoming you all. This is the PSL-23, the Popular Science Lecture 23. So the last six lectures has been done through the web-based application called Discord. So we have also YouTube link. That's also, we are broadcasting it through YouTube link. It's a live broadcast. So I hope that number of people are watching the YouTube link as well. With this, let me start the event, the lecture. This is going to be done by Dr. Ganesh. I'm amazed to see the energy level of Dr. Ganesh when we are doing the testing. He is very much interested to learn the new tool and quickly jump into that, and he is able to come half an hour earlier than us, and he has logged in 30 minutes. I'm welcoming you, sir.
Thank you.
The second thing is the lecture. He is going to talk about the topic of this lecture is management of the new disease called COVID-19. With this, this lecture is being organized by Tamil Nadu Science Forum. Dr. TRG will introduce, say a few words about the Tamil Nadu Science Forum. So later, Dr. Jam is introducing the speaker. Later on, we will hand over the mic to Dr. Ganesh.
Okay. Thank you. Thank you. Welcome, Dr. Ganesan and Vijayan. Thank you for Tamil Nadu Science Forum was started in 1981, and we earlier had a lot of programs, and then we also did a lot of popularization of science activities throughout Tamil Nadu, and we have been reaching schools, colleges, and various other places, and we have been fairly successful in reaching now with some about 40 or 50,000 members, and we run two magazines. One is for school, almost primary school kids who live, and another one Jantar Mantar. And we have been holding for the past 2 years a lot of hall meetings where we take science to college students and people who have gone through science but probably working in other areas now who want to keep up with modern developments in science. So this is the 24th meeting in that series, and our last 6 meetings have been mainly through this online activity due to this sudden developments which have happened. And it so turned out all of them are on the COVID virus, but different aspects of that. The first one was by Dr. Sitabra Sinha of Institute of Mathematical Sciences, who talked about the mathematics of this immunology or developing, followed by several talks, and Sundar Raman spoke, and then later last one was by Dr. Iqbal, who was the chairperson of the core group of the Kerala group for fighting the virus. And now we have Dr. Ganesan with us, and we are looking forward to this meeting. And I will leave it to Dr. Ramanujam of Institute of Mathematical Sciences, who was earlier the president of the Tamil Nadu Science Forum, to introduce the speaker. Cam, to you. Thank you.
Thank you very much, Yaji. It's my pleasure to welcome Professor Ganesan. Dr. Ganesan graduated from JIPMER and was subsequently trained in medical oncology at St. Bartholomew's Hospital and completed his PhD from London. He has been back in India. He was in Amrita Institute of Medicine from 2005 and has been at the Cancer Institute in Chennai since 2012. And he has extensive research interests, has been working on cancer genetics, signal transduction, clinical trials, and has contributed to forming early phase trials by gene therapy, antibodies, and vaccine, in addition to novel drugs in cancer. My association with Dr. Ganesan has also been part of this Indian scientist response to COVID-19, and where I've always admired the quality of his articulation. Every single intervention is, I must say, beautifully considered and highly educated. But apart from all the formal curriculum vitae that we talk about and his accomplishments as a doctor, I also want to mention a tribute from one of his students, so to speak, who had Dr. Ganesan as a mentor during MBBS time. And he says that his entire batch, all their training and understanding of clinical work was inspired by Dr. Ganesan. I mean, that he invariably inspires and informs the thinking of all young doctors who come to him in terms of clinical practice. Now, that's, I think, the best tribute a teacher can have, right? A doctor and as a scientist. It's wonderful to have Dr. Ganesan with us. I look forward to his talk on the matter. Thanks, Dr. Ganesan. Over to you.
Thank you. Thank you. Can I start?
Yes, please.
Thank you very much for that very kind introduction by Ramanujam. I also wish to thank Govindarajan, who's I met before via email, and then more recently with Vijayan and his colleague, who have helped me set up this whole Sundar with this whole setup through which I'm going to give this talk. Now, before I start, I just want to make a few comments. First of all, this is a new disease. There are very few new diseases you're going to encounter in your lifetime as a doctor. And this is a new disease, and I have not encountered many new diseases. And those which I have encountered are all infectious diseases. SARS is one example, and this COVID-19 is another. Second, I'm a medical oncologist. I'm not what I would call an infectious disease specialist. And currently, working in a cancer hospital, we will not be managing these patients. So what I'm going to talk to you today is more from the literature in terms of evidence rather than hardcore, cold-face sort of experience of managing patients with COVID-19. But I must point out, however, a lot of the problems which you see when you treat a patient with COVID-19 are very similar to what you would see when you're managing patients with cancer. Particularly, they have similar type of infections and they get into the ICU and so on. And so we're very familiar with a lot of the problems which COVID-19 has introduced. Finally, I think as any good doctor should be, when you get a new problem like this, particularly an infection, you should be aware of it and how you're going to treat it, deal with it, like any other good physician or surgeon. So with that little intro, I'll move into the lecture. Just one sec. This next is not. I should try and move to the next slide. Next page, yeah. So I want to tell a little bit of the history of this particular virus, and maybe you have heard it before, but essentially the coronavirus was initially identified in the 60s by two groups of people, which you can see here, Tyrrell and Bino, and then Hammer and Prochnow. And they isolated these viruses from people who had common cold. And they looked at it for the next 10 years. And finally, Tyrrell actually, in 1975, published a paper which said, based on electron microscopy and morphology, that this is actually called a coronavirus because of the spikes it has, the crown. Subsequently, it was also shown that 15% of common colds, at least in the US, were due to coronavirus. We don't have similar figures for India, so they don't test for all the different viruses which you actually have when you get a common cold. Now, really, coronavirus came into play globally as a problem clinically in 2003. I remember exactly the same thing happened in 2003 when SARS, which presented as an acute respiratory syndrome, that's why it's called acute SARS, in 2003, which is also from China, and effectively went through to 29 countries, and it was a big problem. My meetings in US were canceled. I had to go to Australia, Singapore, everything was canceled. We couldn't fly. And subsequently, it was shown the virus actually, which they isolated, is a coronavirus, and is very similar to a virus just seen in Himalayan civet. And the hypothesis was that it spreads from animal to human. Now, very similar to the problem we are having now, 20 to 40% of wet market traders were serologically positive without any symptoms. So this is actually a very important thing to remember. Now, the current virus, I'm sure you've had talks about this from other people, so I won't bore you with this in too much detail. But essentially, the SARS-CoV-1 virus, which has happened 2003, is about 80% similar. But the current virus is about 96% similar to the bat virus. And the common cold coronavirus is about 50%. So it's part of the same family. And there are alpha, beta, gamma, delta, 4 different types of members of this family. And SARS-CoV-2 is a beta coronavirus, of which there are 4 types, and we have got the B type. Now, you don't have to worry too much about the schematics here, but the length is about 30 kb. It's an RNA virus. And essentially, it has got multiple open reading frames by which proteins are made, and you get the final virion as it's shown in the illustration. The slide also gives you the evolution rate and the mutation rate, mainly from other members of the coronavirus family. We don't know enough about SARS-CoV-2 to give you a clear idea. Now, this is actually a cartoon which shows you what the electron microscopic picture is. And this is the original coronavirus in 1967. You can see the TEM shows very nice spikes around. I'm just moving my pointer there. And this is actually a colored cartoon showing the same thing in a much better way from the NIH. Now, this is actually a schematic from this review article, which shows the coronavirus. It's a diameter about 100 nanometers, so it's very, very small. And it's got these spikes, which are about 10 nanometers in size. And you've got at least enough, about 100 copies per virion. So that is actually a large number of spikes, so you can easily attach to whatever the subreceptor is. And all these various other information are also relevant, but most of it is from SARS-CoV-1. The AC2 receptor, I'll come back to, it binds to that. Now, this is very quickly, this virus sequence came in January, the early part of January from China. And by February, we had the structure of this spike protein of this virus. This is actually a structure. I can't show you in 3D because this is a PDF file, but essentially you can turn it around if you do it in PowerPoint. And this actually, the blue thing is the spike protein. It's actually a trimer. So this was resolved, and this is very important information to have, and subsequently the Chinese resolved the structure of the ribonuclease, which makes the RNA. So the RNA is actually within the virus, and the surface is all coated and is easily destroyed by lipids. Now, this is actually a way of how the virus enters the cell. You can see the SARS-CoV-2, the essential thing, which is the spike protein, and then you have the RNA in the middle, and then it binds to this receptor called the AC2 receptor. Now, this particular receptor is actually important in maintaining your blood pressure, your vascularity, and so on, and it's expressed in different organs, and I'll show you. So every virus has to have a receptor to get into the cell. It doesn't matter what virus it is. It has to get into the cell to create problems. And so this particular virus has got this AC2 receptor. Now, this is a nice little thing from the same review article, which shows you, which is about SARS-CoV-2, which shows you how much virus you have in the nasopharynx, about 10 to the power 6, 10 to the power 9, huge amounts, throat also. That's why we do these 2 swabs to get at the virus. But very important to remember, in the stool also you can pick up the virus, about 10 to the power 4 to 10 to the power 8. And these are the type of cells through which the virus enters the human body. And you can see the lung cells, which are 10 to the power 11, then you've got the macrophages, and then the cells in the nasal cavity, and all these methods by which the virus gets into the human body. So essentially, it's a very sort of highly infectious virus. Now, it's important to know the AC2 receptor, which is actually the entry route into the cell. And this is actually an amalgam of data, which is actually tells you where is this receptor expressed. That's what is going to tell you how the virus is going to get into different organs. Now, funnily enough, the lung doesn't have that much. So this is actually also about SARS-CoV-1, because the receptor is the same. So it dates back from 2003. But you can see the small gut, small intestine, these blue round circles, almost all the different pieces of data show these are all different pieces of data from different authors. Similarly, the kidney, the testis, the heart muscle. But the more recent data, well, it's not that recent, from 2004, shows that it can infect. But subsequently, people have done experiments where they've expressed the virus specifically in cells from the lung and shown that it can easily infect the lung. So this is important to understand what are all the organs it affects. Now, this is just a simple schematic which shows you, you must have heard this before, the overall picture here. So reproductive number, I'm sure all of you know by now, it's the number of cases which are generated from a single patient. So typically it's between 2 to 4. It varies depending on which part of the world you are in. So here, after you get infected with the virus, there is an incubation period where you don't have anything, and you can become infectious very quickly after that, and along with symptoms, and then you're going to infect not only other people, but also you can become symptomatic and become ill because of the illness, which is COVID-19. Now, the case fatality rate, which is basically a number of patients who are positive for the virus dying from that, varies up to 10% now. And we will know the correct picture only when the epidemic is completely resolved. So then we will know exactly what the case fatality rate is. Infection fatality rate is slightly different because a lot of patients are asymptomatic. So that is much lower if you include them also in calculating the fatality rate. Recovery, about 2 weeks for the mild and more. Now, what are the risk factors? Why do you get into trouble when you get this virus? As you know, large number of people get infected. They have no problem. Only some people get into trouble and they actually die from the disease. So these are some of the risk factors. If you're old, over 65, infants less than 1 year, and then if you have got underlying diseases like chronic lung disease, for example, asthma, emphysema, cardiovascular disease, heart attack, and so on. Diabetes is a key problem, and I'll come back to it, why it's a problem. It's an important issue in India because our incidence of diabetes in the rural and in the urban area is quite high. It's about 20% in the city, and it's about 11-12% in the rural area. Obesity is a problem, renal disease, liver disease, that is kidney and liver problems if you have. Now, but very important, as a doctor who manages cancer patients, immunocompromised people are particularly at risk, particularly those with AIDS, cancer patients, people with tuberculosis, any type of after transplant for kidney problems, liver transplant, heart transplant, bone marrow transplant. All these people are immunocompromised, so they can get infections easily. And that's what we are good at in dealing with. So this COVID-19 in some ways is actually an infection similar to that in the way it presents. Now, what are the symptoms you actually see? Symptoms reflect the organ involvement where the receptor is expressed. That's the most important thing to understand. So you get a whole variety of symptoms. I'm just telling you the initial symptoms you get: fever, headache, cold. You get a very interesting symptom because of the way it goes through the nose into the brain, anosmia, which is a lack of smell. Apparently, it's a very early symptom, which patients often say, and they often miss it also. They don't pay much attention because at the same time, you have got a cold also. So you assume this is due to the cold rather than a separate symptom. Now, fatigue is overwhelming, so is myalgia. And there is sometimes difficulty in breathing, chest pain. You can also have diarrhea and vomiting. So some of these symptoms in the context of what the epidemic is currently going through India should warn you and should alert you to go and visit your doctor and have a chat with him or her to actually get tested. That brings us to the test. If a patient comes to a doctor with these symptoms, how do you actually show? Now, there are also rare presentations, which is important to understand as a doctor, but as a public sort of lecture which I'm giving, it's worthwhile knowing about them. You can get a skin rash, which is not very common, but it can be a problem. And it can even be present after the disease has gone away. That is, your PCR is negative. You can get a stroke, you can get myocardial infarction, which is a heart attack, and you can get this very funny encephalopathy, which is actually ill understood because we've not done enough autopsies. And more recently, particularly from New York and Spain, and more so in India also, this very rare disease called Kawasaki disease, which is a multi-system disease with vasculitis and so on, which occurs in children, is being seen in the context of COVID-19. Then finally, you can also get clotting issues, blood coagulation problems. That is also an issue which you often get with this particular illness. These are rare presentations though. So how do you diagnose? The standard diagnosis is by RT-PCR. As you can see here, you do a swab, you do RNA extraction, and then you change the RNA to a DNA by reverse transcriptase. And then you do polymerase chain reaction, which requires a special machine. It's a fluorescent labeled machine, so you can actually spot it on the screen. It takes about a day. It's a gold standard. Now, initially, when we had the epidemic, this was the problem. Everybody in the forum, which Ramanuja mentioned, said, why are we not doing enough tests? So the problem was we didn't have the kits. The kits were largely manufactured in China. The Americans had not got on top of that either. Neither had the Europeans. Everybody was going to China to get the kits. So there was a whole big problem. But now, 2 months later, we have got a lot of Indian companies who have made the kits. And I've just listed one here, My Lab Discovery Pathotech. And ICMR has said you can go to any Indian kit. They have certified a lot of them. So we can actually use Indian kits. The cost of it also will come down. So this is the gold standard. But I just want to share with you 2 other ways by which you can diagnose COVID-19, the presence of the virus. So this is a particular method which I'm showing you. Here is a swab. You extract the RNA. But this whole technique here in the middle panel, it's based on an interesting observation which was originally observed in bacteria called CRISPR, where it cuts a specific piece of DNA because it recognizes a particular sequence. So here you design a primer, which is a short set of sequence, which latches on to the coronavirus sequence in the presence of this protein called Cas9 or Cas12, as it may be. Now, in this complex, if you put in a single-stranded probe, which is labeled with a fluorescent molecule, this is what was not known before and was only identified about 2 years ago, that it will also destroy single-strand DNA as opposed to double-stranded. Then you get a cut in the single-stranded, it releases, and you can identify this by this little, like a pregnancy test. You look at it and see if it's positive. Now, this doesn't require a big machine, it just requires a water bath. And the whole thing can be done in about 2-3 hours. So it's much more rapid. The Boston group has actually done this, so have people from California, which I mentioned in the reference here. And the Indians are also onto it. In Kerala, they've done the LAMP assay, which is the initial bit. And then in NRI, a group has actually organized the whole thing through CRISPR-Cas9, although they've not published the results as far as I know. But very soon this will be marketable, and it's very specific because the sequence has to be there, it has to hybridize. It's a little bit more complicated in principle, but it's very specific. Now, the third one, which I actually think is a brilliant idea, is actually this lab on a chip. This is by this gentleman, Dr. Tabib Azhar, who's actually an engineer. He made this thing for Zika virus, which was a very big problem in Latin America and US. Now here, what happens is you have a single-stranded DNA aptamer, which is actually based on the sequence of the virus on a small chip, about the size of a rupee. And then you place a drop of saliva on the chip. So if the virus is there in the saliva, which it should be, then it'll hybridize to this aptamer, it'll attach itself. That releases electrical signal, and there is an app which you connect to your mobile, and you can connect the chip to your mobile through the power port. And then it detects the virus in 60 seconds. And the chip is reusable. There is a way of doing that. So effectively, this reduces the whole thing to just 1 minute. It's a bit like your blood sugar test which you do, which incidentally was discovered in Oxford in a standard academic biochemistry lab, which all of us are using it globally now. So it's a bit like that in a way, but it's actually through the mobile phone. It's actually very clever. And I hope this becomes, he's working on a prototype to do it for this particular virus. I'm not sure how much it has achieved or if it's got approval, but this will be a very good way for countries like India. So the overall clinical picture as a doctor is actually these symptoms which I'm pointing out here: fever, cough, fatigue, anorexia, myalgia, diarrhea. You've got a pre-symptomatic phase, and then you get into the clinical problems. So majority are asymptomatic, and the people who are symptomatic, a proportion of them become ill. So about 5% really become really ill. About 15% become a little less ill, so it's still manageable and they'll probably recover. So how do you manage these people? So mild symptoms is not a big issue. You can control the fever, no problem. We've got enough drugs for that. You should make sure they have good nutrition, good vitamins. There is some evidence for vitamin D, which I'm told is being used heavily. And I know the Tamil Nadu government gives zinc also, and various other local concoctions, which I'm sure you know. Bed rest is important, analgesics for the pain, and then this chloroquine business. Now, chloroquine azithromycin is actually on the guideline of the ICMR, Indian Council of Medical Research, but actually a very large retrospective study published in Lancet last week actually showed that it is detrimental. It's not actually helpful. However, I think for prophylactic use, it may be good. That means before you get the infection, to prevent you in a high-risk situation like doctors and frontline workers like nurses and so on. But at the moment, for an established illness with COVID-19, it's probably not a very good idea to give this drug, given the results of the Lancet. It's actually a retrospective study, but it involves a large number of patients globally. The Solidarity trial, which I'll come to in a minute, which is run by the WHO, they've withdrawn this arm based on this report. But the good news is the recovery is 100%. Majority of the patients get better and they go home. So this is actually the best thing about this whole infection. It's a small number, and the sudden epidemic that creates a problem for hospitals and medical professionals. Now, when a patient comes to you with these symptoms and proven to be COVID-19 patient and positive for the virus, if you have an X-ray like this, with a lot of these, this should be completely black, and you have a lot of these little dots, and similarly on the scan, which is a cut of this, or you have a stroke. There's a huge big hole here, which is hypodense compared to the rest of the scan. That means you are in trouble. This is actually what we call sort of ARDS, or acute respiratory distress syndrome. It's actually a syndrome in the sense any particular pathogenesis can produce this. It doesn't have to be only infection. It can be a serious infection, the rest of the body, but nothing in the lung. But you become hypoxemic and you become troubled. So a similar sort of thing is produced here. We understand a little bit more about the pathology now than we did at the beginning. And it's still an evolving thing, how to manage this critically ill patients. So serious illness, which is where we lose patients, and many of these patients have got coexisting illnesses, which makes it tricky. So supportive care is by oxygen, which standard sort of thing. If you measure your blood pressure, just like that, you can measure your oxygen saturation using a small device on your finger. And if it is below 94%, you are in trouble. So you have to give oxygen. And really, most of the patients can be managed with oxygen therapy. In the initial phases of this illness, a lot of people went on ventilators because people had not seen oxygen saturations of 80%. They thought it's inconsistent with life. But actually, ventilation can be quite harmful, partly because you can get infections subsequent to ventilation, and then the lungs become a little bit more tricky to ventilate over time. So 50% of patients die when they're on ventilators. So the initial emphasis on ventilation is less so now. For example, the British Prime Minister, who had this problem, as all of you are aware, was managed entirely by oxygen, although at one point it was felt that he may require ventilation, but he never went on it. and he recovered completely and went home. So similarly, I think even in Tamil Nadu, people are using the ventilator very judiciously rather than putting everybody on the ventilator. So that's very important to understand. It's a dynamic situation and it's evolved over time. Kidney failure, you can support with dialysis, and that is a problem, and I'll show you more data on this. Now, what drugs can you use in this active scenario? Now, corticosteroids is always used by doctors when they have a major problem in the lungs, but it has not been shown to be really beneficial through proper research. But there is some evidence that methylprednisolone can be helpful in the acute situation, particularly when your lungs are in trouble. Chloroquine, azithro, I just told you. Now, more recently, remdesivir, which is a drug which was developed for treating Ebola virus infections in Africa, has been shown in a large randomized trial in the US to have some impact on critically ill patients. So that is something which we can actually consider. And Indian patients are also receiving it. I read it in the newspaper even today. Heparin is also an important part, and I'll show you why it is important when we discuss the pathology. It's a drug which actually prevents clotting. And as part of this illness, when you look at the autopsies, you find there's a lot of small clots in the lung, in the heart, in the kidney, in many places. So there is a clotting tendency here, which can be controlled by giving heparin at the earliest part of the illness. So that is again something which you have learned during the course of this illness. When do we actually ventilate a patient with a machine to make sure he breathes? It's a temporary situation where we want to allow the human lung to recover. So these are all the issues. The most important of which is here, hypoxemia. That is, if your oxygen saturation is 80%, you're unable to improve on it with conventional oxygen by mask or by tubes, and you are in trouble, and your carbon dioxide tension increases, then you have to start thinking of ventilation. And of course, if your systemic symptoms like blood pressure, pulse rate all change, then it is a problem. But as I told you, we are not ventilating that many people as we used to at the beginning of the epidemic. Now it's much more judiciously used. So we don't have to worry too much about getting a run on the ventilators, which is what everybody is worried about. Now, there is one more syndrome, which is part of the lung pathology, which I want to just address briefly. It's called the cytokine release syndrome. Here, what happens, the virus actually gets into the lung and starts multiplying in a big, very fast way. So the immune system, which is comprised of macrophages, dendritic cells, and monocytes, actually come and attack the virus. As a consequence of this, a lot of what are called cytokines, basically their local hormones are released. They're small hormones, and they cause additional damage. There's like a bystander effect or collateral damage. So these things also contribute to the lung pathology. And when you get into the cytokine release syndrome, it can be quite difficult to manage it because ventilation is not going to solve it. Similarly, as the hypoxemia, ventilation alone is not going to solve it because the oxygen supply is lower. So you have to be very careful about using ventilation beyond a point. So here some drugs are there available. We see this particular type of syndrome in patients with cancer as well. When you treat them for leukemia in specific circumstances, we do see these type of problems. And more recently with chimeric antigen receptor therapy, you have got this very high levels of IL-6. And there are drugs which prevent this IL-6 levels, and you get very rapid recovery. And this has been shown to happen in small studies with tocilizumab, which is available to treat these patients. And I think Indian patients are also receiving this in a few instances. Now, what is the pathology in the lung? As a doctor, you should know this. Look at the lung here. It looks pretty terrible, a lot of hemorrhagic spots. And here, a lot of inflammatory cells, the blue sort of things are all inflammatory cells. The spaces are the alveoli, which is where the air gets exchanged. But this small little cartoon here, image here, shows that there are blood clots, this pinkish stuff, inside the blood vessels and inside the alveoli. This is where the problem is. And this is actually from a recent publication in EGM. Now, the normal lung on scanning electron microscopy looks like this, but the normal lung, because of COVID-19, looks like this. The whole architecture is destroyed. And here in the scanning, you can also see a little bit of the virus here, or TAM here, little bit of the virus here, small particles. And these are actually more detailed definitions of the alveoli to show there are holes here which actually represent where the virus targets. Now, similarly, in the kidney, you can have problems where you have, this is actually from China, where they have done postmortems on 26 patients, and they were actually sure they all had acute respiratory failure. You can see the white patches in the lung. But you also see that this sort of RBC aggregates in capillaries and some amount of clotting. And then you can see the virus here in this black picture in electron microscopy in the tubules. And this is also shown by fluorescence microscopy. So it actually can go into the kidney and multiply. So it's very important to remember that's one of the reasons why these patients with diabetes who already have kidney damage because of long-standing diabetes or heart disease, patients with hypertension also have kidney damage. Already the kidney is impaired, although it may not be apparent. When the virus starts attacking it, then it becomes a big problem. Then finally, this coagulation. This is a very recent recognition. It was not very apparent. A lot of people realized as they were managing, particularly from New York and Europe, and now it's even apparent in India. In fact, Alok Srivatsava from CMC wrote a small article this Sunday, I think, in Hindu about this. And essentially, because of all these reasons, the endothelial cells are actually affected. The virus multiplies in them. That's a lining of cells in the blood vessel. You also get clot formation because of the activation of the pathway. So because of all this, clots are formed. And when they form, the blood supply is blocked. And that is another problem, why organs get damaged and beyond repair. So, okay, now that we have managed a seriously ill patient or a mild symptom, after the patient recovers, what happens? So there are mental health issues, isolation, fear of death, stigma. So these are all important issues. And many people, I'm sure, have read in the news that people have committed suicide once they were put in isolation because of COVID-19. And they also have terrific problems after recovery. And also there's a lot of interpersonal problems because you're confined to the house during the lockdown between the husband and wife and children. So this is a big issue. Of course, the migrant, I won't even talk about the amount of mental health issues they would have had. The physical, of course, after recovery also you can have breathing problems, fatigue, and of course we don't know how much recovery will take place in the kidney and liver when they have damage. So it needs follow-up. Finally, from an academic point of view, you need to know how long does the antibody response last? Can they get a recurrence because of infection? There is some reports from Taiwan, from Korea, and China even, that patients are coming back a few weeks later with another episode of infection. I suspect these are repeat infections. That means your antibody response is still not good enough to get rid of it. And so this is a moving story, and it'll take a little bit of time to get grips with it. Now, I'm going to, the last 10 slides or so, I'm going to focus on what we are doing in research. So essentially, you need drugs to treat the active infection. If you can get on top of it, like you get onto with conventional pneumonia or tuberculosis or any other infectious disease, then you are, then the worry about this new problem is not going to be there. So this treatment is based, a lot of the drugs we're going to use are drugs based, which are discovered for other viral infections like SARS, HIV, hepatitis, and so on. Now, identifying a new drug from scratch is a very costly affair. It costs about $1 billion per drug, very easily. And we want some drugs very quickly. So the quicker way to go is to repurpose drugs, which you already have, and you can screen them. Now that we have the structure of the virus, you can screen them. So that is actually a very quick way of actually identifying drugs. Now, screening is also, you can also design drugs based on structure. Now, while I was on this, somebody actually sent a message saying, can you tell about the low mortality? Now, the reason the mortality outside India is high, and part of the reason for that is a lot of the old people in nursing homes are dying much more quickly. In India, that's less of an issue. Secondly, we have a younger population. so which are able to take the disease and get better very quickly. So those are the two reasons I can simply give. There are other causes, and we can discuss that when we come back to that. Now, what are the targets actually which are important for identifying the drug? And there are many of them I've given here. That is before the virus gets into the cell, and then how it gets into the cell. And once it comes into the cell, there are drugs for every aspect. So all these drugs, which you can see on your screen, I'm not going to mention them all. They're all on trials to try and make sure that they actually have an effect on this particular disease. Now, some of them I'll mention here. Chloroquine, I've already told you. Now, these drugs, lopinavir, ritonavir, and darunavir, are actually HIV drugs, but they can work in this situation. Ribavirin is another drug which works against the RNA polymerase, which is very important for the virus because it needs to replicate and make more RNA. Now, oseltamivir is an old drug. We used it for SARS also. It's against influenza, but apparently it's also being tried, particularly in China. This is a very interesting drug, Uminofivir. We are going to trial it in India as well. It's against the spike protein AC2 interaction. So unless the spike protein gets into AC2, you're not going to see any effect of the virus getting into the cell. So this is a very interesting drug. So that's going to be trialed. Interferon, of course, is what we produce in the body naturally to attack viral infections. So it makes sense to look at it in greater depth. Then finally, these drugs which are used to treat worm infestations have been shown in the laboratory to actually have good effect against the virus. So people are actually looking at that in clinical trials as well. Now, there are some investigational drugs which are actually not licensed for this particular thing, for anything actually. Remdesivir, I've already told you, has been approved now. Then this favipiravir, again, we are going to look at it in India. It's another drug which is actually can be effective. Tocilizumab and serlimumab are both actually drugs which affect the IL-6. Now, fusion proteins are very interesting. There's a very nice article in Cell showing that you can actually use these fusion proteins to actually part of the AC2 receptor. It competitively inhibits the binding of the virus to the receptor. Now, passive immunoglobulin is your plasma therapy, which all of you know, it's in the press. It can be done so long as you have a measure on how good the immune response is in the patient. So that is something which is being trialed, not only in India, but all over the world. So for those of you who are not familiar, I've just briefly mentioned about this. You need clinical trials for all proving efficacy. Now, the best trial is where you compare a new drug plus supportive treatment versus supportive treatment. That way you get hard evidence that your drug is going to do something. You can also do smaller trials, which are phase 2, which will tell you whether your new drug is going to be worth proceeding to a phase 3. Now, there are mechanisms by which you can take a new drug in a phase 2 setting itself and give it license. Say, for example, you have got a drug which cures 80% of the patients with COVID-19 who are seriously ill, then you don't need a phase 3 trial to confirm. You can start using the drug. So that sort of thing also is there. Now, the Solidarity trial, which I mentioned briefly, is run by the WHO. It's a very large multi-arm trial, adequately powered, about 10,000 patients. And India is a participant of this trial. So it's important to remember that this is very important. Now, finally, I'll come down to the last few slides on vaccination. Now, vaccine is the only way you're going to prevent this disease completely and eliminate it from humans. So similar to smallpox, similar to poliomyelitis. We couldn't get rid of smallpox by any drug. It's a horrible disease, 30% fatality rate. We got rid of it. Polio causes so much of disability. We got rid of it. So essentially, you need a vaccine. It has to be safe. It has to produce immunity. And it has to be effective against all age groups. And you should be able to manufacture it at large scale. That is very important. And you should be able to distribute it equitably. Now, during the Ebola virus, which is 100% fatality rate, very, very serious infection, this particular vaccine was tried and it actually was efficacious, 100%. And similarly, the Oxford-based adenovirus vaccine was also tried, although not in the same extent as the previous one, and that gave very similar results. Now, what are the type of vaccines you're talking about? You may have heard this before from others, but I'll just mention it. Whole virion-based vaccines are attenuated or inactivated. So these are basically like polio. So polio virus is weak virus is what we take orally, and then the sort of inactivated virus is what is given by injection, the Sabin and the Salk vaccine. Now, protein subunit vaccines are also important. That means you prepare artificially a protein of the virus, like the spike protein. You mix it up with some lipid so that it's encapsulated, and then you give it to the adjuvant or virus-like particles, and it produces immunity. Now, the HPV vaccine is a bit like this. Virus-like particles are made. Nucleic acid, we have not done very much in nucleic acid, which is basically you inject DNA or RNA. But the recombinant viral vector is also very promising, where you use common viruses which are not pathogenic to humans, like adenovirus, common cold virus. And the pox virus here is cowpox virus, not smallpox. And the vesicular stomatitis virus. You can take them and put bits of your SARS-CoV-2 in them and then inject it to patients, and they can get immunity. So these are the different approaches. Now, already there are vaccinations which are available, live inactivated protein, nucleic acid, viral vectors. And these are all the companies which are made using these techniques, so different approaches. So they're all looking at COVID-19 vaccine. So in fact, there are hundreds of vaccine research going on, huge number, including in India. So the clinical trials for which we already have some information and some signal, this is RNA-based vaccine from US, Moderna, and this is from Germany. Both of them have crossed the phase 1, which is the initial test of safety. And then they're going to have larger trials. DNA-based vaccine, again, these two have passed the phase 1. The viral vector from China, and this is from Oxford, has also gone through the phase 1. And the Oxford one is actually very close collaboration with the Serum Institute in India, and they're going to manufacture a large amount of this vaccine. Now, if you look at India itself, unfortunately, there is no position paper which tells you what are all the vaccinations are being tried in India. So this is actually after talking to a few people. Serum Institute is making this vaccine in collaboration with Oxford, plus a couple of other things. These are only the main things I'm talking about. Bharat Biotech, which is a very good vaccine manufacturer, is taking Indian isolate from NIV in Pune. Similarly, Minvax, which is a protein-based vaccine from Indian Institute of Science, Cadila is doing a DNA vaccine, and Indian Immunologicals Australia. Now, BCG is being trialed again. BCG is against tuberculosis. But there is some evidence to suggest that in India, where everybody is vaccinated with BCG, the intensity is lower, and the mortality, as we discussed before, may also be because of this, compared to European or US countries where BCG is not given anymore at birth or in the infancy. So this is again going to be trialed, not only by us, but also Australia and many other countries, to actually, because it's already there. We know a lot about BCG vaccine. So these are some of the vaccines which are going to be trialed from India as well. Of course, a lot of research is happening in India too, diagnostic as well as drugs. I've not mentioned all of that, but they are happening. So to summarize, so in prevention is the key here. Of course, conventional prevention, like with mask, physical distance, and hygiene, that's common sense, and all of you will agree. A mask is probably the most important, followed by physical distance and then hygiene. Because the virus actually is quite heavy and falls to the ground. So if you're 2 meters away and you're protected with the mask, you're unlikely to get infected, or the risk is less. Vaccination, of course, is the permanent strategy, and that's why everybody is scrambling around to get to a vaccine. And we may have, at the end of the year, probably 2-3 vaccines to actually given to patients based on the efficacy. Now, symptomatic patients, only 20% are of the infected variety, and 90-95% are going to get better. Tamil Nadu stats are very good. Only 5% get ill, and we have to learn how to manage them. This 5% of populations who get infected is actually quite huge, because India's population is very big. That's why there is a problem in how to manage them, to get ventilators, to get ICUs, and so on. But it's only by participation in research trials that you're going to get really to the key. Otherwise, you're going to be in trouble because we will never know. So whatever thing you use, whether it is Ayurvedic medicine, Siddha medicine, or some modern drug, you have to show with evidence that it actually makes a difference. Now, you can start with the phase 2. There's no problem. That's a small study, maybe 50 patients, and it can tell you very quickly whether that's worthwhile proceeding further. But that has to be done. And I'm sad to say, although a lot of trials are being put in place in India, there is not much of publication on the clinical course of the illness from India and their experience. That is one of the, compared to what's coming out of China or Europe or US. Now, the most important thing to remember for all the people here who are listening to this is recovery is the norm for the majority. So you don't have to feel in some way, all the problems we have seen on the television as though it's going to catch you. So long as you observe common sense precautions, you'll be fine. So with that, I will finish. Stay safe and be prepared for the long haul. And I thank Tamil Nadu Science Council and their executive committee to give me this opportunity to share with you. I'm now happy to take whatever questions you have, and I will try and answer them to the best of my knowledge. Thank you very much. Who's the moderator?
So we start getting some questions. Read the questions one by one. In the meantime, I request all the participants to write your feedback. So your feedback is important for us, and we will be preparing a report, and we will read the report next PSL meeting. So please fill up the feedback form. We provide the link for the feedback form in the Discord text window. You just go through that and you just click the window and fill up the feedback form. So let me go to the question answer session. We see only one question has been pinned. Can you tell what could be the reason for low mortality rate in India? That's better.
You want me to answer that now?
Yeah.
See, that I did allude to in my talk when the question popped up on my sort of screen.
Okay.
See, essentially, there are multiple reasons. One, India has got a very young population. The majority are young rather than old. Number two, the sort of where we are in the whole epidemic is a little bit later than the rest of Europe. For example, in China or in Europe or in US. So that's the best I can give. In Europe and US, they didn't have all this contact tracing. They didn't have this type of severe lockdown. So it was much more easily spread. And the old people who were in nursing homes and hospitals got affected. This is particularly so in UK, Spain, and Italy, and to some extent in US as well. See, the type of measures being taken in India are not being taken by any of the countries, except China, of course, in the same sense, particularly Europe and US. So the simplest way to explain is a demographic issue. I don't think at the moment there is any evidence to say that Indians are actually have got some special genetic basis on which you can explain why the mortality is low. I think we also learned over the last 2 months how to manage these patients compared to China or Europe, because they were the first to get in trouble with these patients, and we are better off now. So we probably, and I'm hoping that we will have some drugs in the next 2-3 months, so our mortality will be even lower. So unless we do more research, we will not understand why some patients do not have any symptoms and get away without any problem, and some patients get into serious trouble. And of course, our problem is also this diabetes, and it affects a lot of blood vessels. And this virus grows in blood vessels. Now, what is the status of plasma therapy now? So that is something somebody has asked. Now, plasma therapy essentially is a trial which is ongoing throughout India. ICMR is collecting. Somebody in the forum actually raised this issue, and many centers have signed up to it. So we will not know what is the outcome for a while because it's a trial. So you'll have to wait for at least 100, 200 patients to be treated before they find out. But technically, it should work. It should give you some time. It will not cure you. It will give you some time. Now, the Oxford vaccine basically is actually quite well advanced. Essentially, they have done the phase 1 trial. They're going to be recruiting for the larger phase 3 trial very soon. And already the Serum Institute of India has started manufacturing the vaccine, thinking it will be protective. Of course, the animal experiments were not that great, about 50% protection in monkeys. So that's going to be very difficult to. How do you manage a cancer patient affected with COVID? Well, in our hospital, what we have done is COVID-19 positive patients are shifted to General Hospital in Chennai because we are not a COVID-19 hospital, and that requires separate building. Everything has to be in a different way. Now, in general terms, there is no difference. You manage it the same way. That's what I say when my colleagues ask me this question. But there are little things you can do. You can reduce the intensity of the treatment so you don't get infections, whether you're treating it with radiotherapy or chemotherapy. Now, surgeons, of course, have to be very concerned because they have to protect themselves. So essentially, they have to take care of themselves. Yes, we do ask every patient who comes to Cancer Institute to get tested after taking their history and so on, because it affects other patients and also the staff. I think I answered that question. Let me see if is there any other way to see these questions or only the little link which comes through? Is that right?
See all the pins.
There are questions in the queue. Can we go as per the queue?
Yeah, the same things are coming, so that's why I'm asking.
Okay.
So, because I've already addressed some of these questions.
That's the reason we are pinning the questions. Some questions we are not pinning it. So those questions which has already been asked, we are not pinning it.
All right.
There is a link saying see all the pins.
Yeah. Just click the pin. You can see drop down questions now. Those questions.
Yeah. Where is in the Discord?
Yeah, in the Discord, top left you have the pinned messages.
Oh, where is the top left?
That's the top.
Top right.
Yeah.
Top right or left?
Top right, you have a pin icon like pin. You can just click the pin. Otherwise, I can read the messages.
Where is this icon? I don't see it.
You see an icon like bell next to the bell.
Next to the bell.
You see an icon like bell.
Top right.
Yeah.
Top right. This one?
Yes.
Jam. It says home. It says popular science lecture. Add a server. I don't know where it is.
If you go in the hall text.
Sorry?
Just let Vijayan read the question and you answer.
No, I don't know where this bell is. But anyway.
Just let.
No, you said top right.
If you go to the hall text, you see the top ribbon. Top ribbon, you see the bell.
Recording, Craig, entire screen. Ribbon.
Hall text.
New mentions.
It's a hall text. Click sir.
Sorry?
Hall text.
All right. I think if you send me this pug message thing, I will answer. That is quicker.
Why don't you read the questions? Vijay.
Okay. You can read the
questions. From the bottom, first question you answered. Second question from TRG. Why the mortality is different in different places?
That I answered with respect to India.
Yeah.
Is that right?
Yeah.
Not only with respect to why it is different for different places.
No, that is what I told you. There are two factors. One is the age. If you compare India with other countries in the world, the age factor, that is definitely an issue. That is the simplest thing you can say. Within India, it's more difficult because See, the medical people also are getting used to how to manage these patients. So it takes a little bit of time. All the paraphernalia you require to manage, ventilators and so on, PPTs and so on. So I think that's all now. So the mortality rate should not be hugely different between different parts of India. Of course, you have to have access to good medical care, and you have to have good, proper hospitals there. So I think the medical management is one issue. I cannot see any other reason. As I told you before, research is the only way we will understand this a little better.
In Gujarat, it is about 10%, and Bombay, it is about 6%, and Tamil Nadu, it is 0.7%. There seems to be too much difference, no?
I agree with you. There is a difference. See, the problem is, I'll tell you for cancer, for example. If you take cancer, Northeast has got a very high incidence cancer, some cancers compared to Tamil Nadu. So this is something which is research in progress, even for cancer. We don't understand why there's a difference. So with respect to the mortality, I think the simplest thing is assuming the medical facilities are equivalent between Gujarat, Mumbai, and Tamil Nadu and Kerala. Then you have to look at other factors. Now, given the volume of disease in Mumbai and Gujarat, seriously ill patients, I don't see in the list what is the proportion of seriously ill patients. That's what will determine. I think Tamil Nadu, at least in the evening presentations, they say how many people are critically ill in the ICU. Very few, less than 5. Whereas Mumbai, I think, has got a little bit more, and then similarly Gujarat. So it depends on proportion of patients who are critically ill to account for the mortality. So that is something we'll have to wait for the epidemic to sort of come to a close before we understand that better. At the moment, I don't have anything more to say because there is no publication or no analysis of the mortality between different states. So that's what that has to be done. ICMR should take it up urgently, in my view.
Okay. Next question is from Dr. SK. So in India, there have been reports of infection of pregnant women who have given birth to healthy babies.
Well, see, this is because this can happen. Babies also can get infected because they are close to their mother, of course, through any other route, like we normally two adults get infected. But transplacental transmission is something we'll have to see. China has got the best experience on this compared to other countries because they've had the epidemic for a longer period of time. And transplacental transmission is not so common as it is in some other illness like hepatitis B. So unless the virus gets passed through the placenta, it won't happen in the baby.
The next question, Aparna. Sir, one of the symptoms was mentioned on anosmia. Can you please brief what it is?
Oh, anosmia is very simple. It's just a fancy word for losing your sense of smell. That's all it is. So if you cannot smell your whatever, onion sambar in the kitchen, then you're in trouble.
Next question.
That is already been.
Yeah, so a lot of questions. The next question. So India and Oxford vaccine. India and Oxford vaccines. Any status?
Yeah, that I answered actually. The Oxford vaccine is actually fairly advanced. I mean, they have done all the phase 1 trials. They've done some of the phase 2 trials. They've done preclinical work in collaboration with the US. And they are actually collaborating with Serum Institute of India to actually make the vaccine. And he's already started doing that, assuming that it'll actually. So I think the UK vaccine is quite far ahead, like other vaccines, which I mentioned during my talk.
The next question is from Sundar. The major problem of COVID-19, it affects lungs. I'm reminded of limousine in ABVD for treatment of a certain type of lymphoma. Limousine is still being continued.
No. I think the lung pathology which you see on the X-ray is actually very similar to what is called ARDS, acute respiratory distress syndrome, where the etiology or the cause for that is multiple, not just one disease or one drug or whatever. Anything which causes that type of pattern on the CT scan is called ARDS. And here, we are still understanding the pathology completely. We are not understood it completely because it requires postmortems, which cannot be done so easily as you understand. So it produces clots in the lungs. Somebody has asked me. That is very clear. I showed in the slide also. And secondly, it produces reduction of oxygen, dramatic reduction of oxygen in the exchange between air and the blood vessels because of this blood clots. So you will have to give heparin to a lot of the patients who are ill and who are having hypoxemia before you lose them. Heparin in different ways can be given, so it's very important to give that. So I think the lung picture which you see on the X-ray or CT scan is similar to many conditions we see. But here it's slightly different as to why that is happening. That is what we are still doing. Initially, ventilation was being used a lot, but now we're back on the ventilation. I think with oxygen and maybe with heparin. Advice for diabetic patients. I think your diabetes has to be controlled. This has been written up in the Hindu, at least, many times. Basically, you have to control your diabetes very well, as much as you can with insulin or oral drugs. If you're uncontrolled diabetes, it's always a problem for any infection, for any problem, whether it's cancer or any other non-medical problem. The control is available. What is that question on vaccination? I didn't see that.
Next question is from Jam. How do you decide the severity of an individual patient?
Okay, that's a very good question. So basically, you will have to monitor the patient very carefully. So let's say a patient is admitted, he's COVID-19 positive, and he is asymptomatic when he comes to the hospital. So how do you monitor this patient? Particularly if the patient is, say, 60 years old. So he or she, you have to monitor the pulse, the blood pressure, the oxygen saturation, do an X-ray, do a CT scan, all those things you have to do, and all the blood workup which you need for kidney, liver function, and so on. So the key thing is monitoring the oxygen and looking at the X-ray. So if they are actually going to get worse, you will know that. Now, already people have created little scoring systems for these patients to work out who is more likely to be ill. We have some non-specific parameters which we measure in any acute illness like LDH, C-reactive protein, which can tell you that this patient is likely to be more sick. So people are also looking at these what are called biomarkers to predict who is going to be more sick. But I think the oxygen thing is quite simple. It can be done. All the blood tests are important. An X-ray repeatedly is also important. That will tell you who is going to get into trouble and how you will handle that, whether you will increase the oxygen supply, whether you will ventilate the patient, whether you need dialysis because his kidney is failing, and so on. Next question.
Next question from Sukumar. He is asking, like smallpox vaccination, it's mandatory, all should be vaccinated.
I think yes, because if you want to produce herd immunity, then you need at least 80% of the population. People quote figures of 60%. But if you look at, for example, the vaccinations we already received in children, in infants, the measles, mumps, rubella, and that type of vaccine, when the frequency of vaccination coverage goes down to 80%, then there are small outbreaks of measles or mumps or whooping cough. I think Kerala had one with diphtheria when I was there. So this is because the vaccination goes down. So you need at least 80%. To cover 80%, everybody should get vaccinated. Yeah, I think so.
So next question from Manasa. She says, because of the fast track vaccine being produced against corona, will there be serious side effects? This needs long time monitoring for the safety.
No, see, vaccination of all the strategies I've told, except for the live vaccine, which is attenuated, all the others are artificially produced. Okay, so there is no side effect, absolutely nothing, very little. You may have some mild fever or some soreness at the site of the vaccine. The live vaccine is different, so that we are allowed to discuss. But generally speaking, we are giving so many vaccinations to children. The side effects are very minuscule compared to the benefit which is enjoyed by the public at large. So I would not worry too much about side effects. But because you're looking at healthy people, you're going to vaccinate healthy people, you need to know for sure that there are no major side effects. That's why all these trials are being conducted. Yeah. Is that next question?
Next question. What's the methodology for treating other patients during COVID-19 times? There are news that patients, including critical patients, are refused treatment fearing COVID-19.
Well, you should ask. Well, I don't think any patient should be refused treatment because he's COVID-19 positive or COVID-19 negative. As a doctor, you have to treat all patients when they are ill. That is very clear. But unfortunately, because of fear, this happened when HIV was first discovered. People are avoiding these patients. They were put in one dungeon room. Doctors didn't want to look at their patient. Nurses didn't want to deal with it. Society was lost. The same thing is happening with this illness, unfortunately. But I think everybody should have the same treatment. But I think doctors are better equipped today than they were 2 months ago. PPTs are available. In our cancer hospital, we are seeing all patients as normal as we would see. But transportation is still an issue. Patients who are outside Chennai are unable to come. Even if they're able to come, going back, they are put under quarantine again because Chennai is a hotspot area. So these are all issues that need to be sorted out at the administrative level.
Next question. When vaccination is available, would it be administered for elderly and also high risk? Also,
yeah, I think for sure. I think the high risk people should get it first, who are higher risk of mortality, and then the younger people also. But we also need a good antibody test before we start vaccination, partly to find out if you've already been infected, whether you have good antibody response. So that also will help you decide whom to vaccinate. I suspect we will have enough vaccines available, given the way everybody is geared up to produce millions of doses, that we should be able to vaccinate everybody. Next question.
Yeah. Next question from TRG. Does virus induce clots in the lungs?
Yeah, it does. It does. That's what I showed you in that little picture. You may not have appreciated it. It was a very small picture, but it does. I mean, the clotting mechanism goes awry with this virus because it interferes with the normal clotting process. So you do get clots in the lungs, and that may be one reason why you get low oxygen saturation and hypoxia.
So what's the advice for the diabetic patients?
Diabetic patients, I think if you're a known diabetic, you have to make sure you are in control of your blood sugar and make sure you tell your doctors who are managing you. I think the reason many diabetic patients are dying is partly because their diabetes is not well controlled. And secondly, they've got complications of diabetes which are established, like vascular problems, like kidney disease, like eye disease, heart disease, and so on. So in that setting, this virus actually goes into blood vessels and multiplies. It produces blood clots, as I've already told you. So it cuts off circulation even more. So whatever pre-existing problem is there in the kidneys, heart, and so on is exaggerated by this infection. So you're more likely to get into trouble and as a consequence die from this. Next question. Are we exhausted?
Yeah. Next question. Once the vaccination is found, will it be necessary to vaccinate patients who have recovered also?
Well, that's what I was alluding to. Scientifically, if that patients, like if you get, for example, some infectious diseases, you get lifelong immunity after you get the infection. You don't have to have vaccination. We do not know with this particular illness if it's going to be lifelong. So I suspect it is not going to be lifelong, probably a year or two, and then you are at risk again. So my advice would be to get it vaccinated. But I don't have hard evidence for that. So for that, we need more research as to one infection, what it does. Some diseases you don't like. For example, you get chickenpox. You will never get chickenpox again. So if you get measles, you'll never get measles again. It's lifelong immunity. But it's not the same with this virus. We don't know. At least with SARS-CoV-1, the immunity was not lifelong. It only lasted for a period of time.
So next question, Dr. Murugavel is asking, Doctor, what must India do starting now in terms of R&D investment or science education to be better prepared for such pandemics instead of waiting for testing kits?
Well, I think India has got a lot of funds already put in for R&D. I think here we were caught napping. Basically, the Chinese problem was known to us from January. That I think a lot of people felt it's not going to happen in India. So I think we were a bit slow off the thing. That's why the kits and all that were a problem. Otherwise, we could have done that very fast. It doesn't take a long time to make the kit. In my lab, I can do the whole experiment in one day if I know the sequence. The sequence was published in January of this year. So it's not impossible to do this ramp up very fast. Of course, industry also has to be very sensible. And I think they all started looking at this seriously only in March after the lockdown. So that's why the kit business was an issue, PPT, everything. But now, see, you're getting masks being made by everybody. It's easily available in the market. PPTs are being made very easily. And I am told even ventilators are in supply. And certainly the number of companies who are offering diagnostic kits are also increased from India. And so, and the newer methods of diagnosis are also being established. So I think we were a bit late. We didn't take into account. See, we don't have the Institute of Virology is there in Pune, but our viral illnesses are different. So we never thought this particular virus is going to affect us. Although Nipah came in Kerala, and a lot of research is being done in Nipah, which didn't affect many other countries. But we didn't have that large coronavirus lab, which is there in Wuhan, which is already looking at this virus. But of course, R&D investment should go up, I would say, so that universities, which is where the bedrock of research is, can actually do a lot more. Unfortunately, in India, universities suffer a lot more than freestanding institutions are funded federally. Next question.
Yeah, another question from Parna. Ideally, what should be the distance we need to maintain to avoid this catching infection?
Well, from all the studies I have looked at, 2 meters is the ideal scenario. I think you can, of course, more than 2 meters is even better, but minimum of 2 meters. 2 meters is what you're looking at. That's over 6 feet. So you're looking at 2 meters to actually make sure the virus doesn't come. Yeah, next question.
Yeah, next question is from Sankar. Political community from various has been blaming China for being close to this. What is the view of scientific community?
Well,
the infection started in China and spread as China deserves all the negativity.
No. See, I mean, China definitely, the virus started in China. I think there is no dispute on that. Everybody agrees. The question is, did it actually, was it accidentally released from a laboratory or did it start in that market? That is the question that has to be resolved. But I think we don't have a proper inquiry. Chinese government says it is not from the laboratory, which is in Wuhan. It's actually a very big laboratory which studies coronavirus. So there is a genuine concern But the lady Xing Li, who's actually the scientist who's done a lot of work on this area, actually has said categorically it is not from the lab. But there are others who disagree. I don't think we'll ever find out an answer to that. But I think the virus definitely came from China. There is no doubt about that.
Yeah. Some more questions are being typed out. I have one question on the diagnosis. You are talking about the Dr. Masood Chabi Banzar Zika virus chip.
Yeah.
Can you brief about the usage of such kind of chip for diagnosing the coronavirus?
Yeah, that is actually he is making one for coronavirus. Unfortunately, there is no publication on that. So I cannot show you that with reference to a paper. But he has made one for Zika virus. And I think if you make one for coronavirus, see, can you imagine how easy it is to take blood sugar now at home?
Yes.
Just a small pinprick, you put it on that thing, and the meter tells you what is your blood sugar. It's a small little strip which goes into the machine. So here, instead of the machine, you use the mobile phone. The chip which goes into the mobile phone can be plugged in through the power port. And the whole thing works very simply. So it's actually fantastic in my view. 60 seconds, you will get a result. I mean, for blood sugar, it takes what, 10 seconds, 5 seconds to give you a result? So it's very, very good. If you can have a test like that, then this contact tracing, everything will become much easier.
Okay. We have one more question from Aparna. Sir, can you brief us a little more on remdesivir drug?
Okay, remdesivir is a drug which has actually originally identified for treating patients with Ebola virus infection. It was not very effective for Ebola. So they are trying it for, because it has got the same sort of viral problems. So they are trying it for this particular infection. And the large trial, which was done in America, evaluating this drug, showed an improvement in mortality rate in seriously ill patients. So it's not, a sort of a wonder cure drug, but certainly it improved it. So obviously, in the current scenario where we don't have much, and US is suffering a lot in terms of number of deaths, it's almost it used to be huge numbers every day, and they've lost huge number of 100,000 people have died. So they want to have some drug, and this drug looks the best at the moment. So it acts in the virus, similar sort of ways that it does on coronavirus. If you want, I can send you a link on detailed understanding of how the drug works. Next question.
Yeah, we have a question from Sibi Bharat. When we look at the problem in terms of managing a new disease called COVID-19, how do you see this social lockdown being exploded or diluted by economic pressures?
Well, that's a political come economic question. It's not a medical question. But I think the lockdown was required to set up the medical infrastructure to handle this epidemic. I think there is no doubt. Nobody likes a lockdown. But how do you actually ensure that everybody understands, A, what the disease is? It gives you a little bit of time. Whether it should have been extended for such a long time, nearly 2 months and even more, I'm not sure. We certainly have now over 100,000 cases here in India. Our mortality is still on the lower side. I don't know whether it's because of lack of capturing it, but certainly it is low. And we have not had the same run of mortality as US had or parts of Europe. So in that sense, the lockdown has helped. Of course, there is an economic impact. And now slowly we'll have to learn to live with the virus. You see, there is a question of learning also. People have to learn that this is a virus is not going to go away. See, when smallpox was very prevalent, that's what one old lady has told me, that this is very similar when we had smallpox. We used to shut the person in a room, We'll put all this neem leaves outside the door so nobody will come into the house. We'll wait for 14 days till the scabs fall off, and food will be served to that person in the room. And then when he comes out, things will get better. That's how they manage smallpox, despite 30% fatality. So I think we have to learn to live with the virus. I think then this economic issues will slowly get sorted out. But because it's new, the lockdown was required because we didn't have the capacity medically for all the diagnosis and the management, which we now have. I hope that answers that question.
Yeah. The next question from Sibi again is hereditary immunity is right way to go. I don't know what it is. Herd immunity. I think he's talking about the herd immunity, the right way to go.
Well, herd immunity is not a strategy. In the sense, you cannot work on herd immunity to get a grip on this disease. Herd immunity is the ultimate way. So that is usually done by vaccination to some extent. If you have a virus which is very mild, then you can get very rapid infection and you can get 60-80%. See, if India's population is 1.3 billion or 130 crores, so you have to imagine 65 crores have to actually get infected and become immune. And 5% of that are going to become very ill. That's a huge number. That is why we are not worried about herd immunity. That is what will happen. That may happen over a year, 2 years, I don't know. But if we get vaccination before then, we can force the herd immunity to happen, and then the disease will die.
Again, another question from Sundar now, and he is asking the same question. I think it has not been clear to him. His question is, ABVD is a method of treatment for certain type of cancer. Blemicine invariably affect lungs and leading to mortality. Is blemicine still being continued? He is asking something about cancer.
I'm not understanding the question. I understand the bleomycin, which is used in lymphoma, is still being used. Less so. It can cause similar sort of problems in the lung. Absolutely correct. It's not because of infection. It's because of hypersensitivity reaction. And it does cause similar problems. But I personally don't think that we are using so much bleomycin as we did before, because there is evidence to suggest that you may get away without bleomycin in treating patients with Hodgkin's.
So next question is from Bindia. Do we need to worry about asymptomatic patients in transmitting diseases?
Yes, we have to worry. We have to worry. That is the only way the disease is going to get spread.
Yeah.
So we have to worry. So that is why all this contact tracing is done. Unfortunately, in Europe and US and UK, they didn't do this. So they are in big trouble. They've got 300,000 patients. They've got a huge amount of patients dying. Fortunately, we are not in that shape because of the contact tracing. So that's why the diagnostic test, if it becomes simple, then we can trace the contacts much more easily. Now it takes a day to do the tests, and we have to do, and there's a kit issue also. So we have to get rapid, quick, effective diagnostic.
Yeah. So almost all questions are done, and we have 2 minutes to go to close the session.
Okay.
If there is no question, we can close the session now, and people can
Thank Dr. Ganesan.
We can mail it to you. I see some people are still typing. Yeah. So they said, thank you, Doctor, for awesome talk and discussion, learning issue. Thank you all. Okay. So I think there's no question. I think we can close the session. TRG, you want to say anything further?
So I just wanted to ask one small thing. There was a report today from NCBS that the asymptomatic cases, the virality of that virus is reduced or weakened. Is it true?
I don't know about this particular report, so I'm trying to understand the question. You may not have rephrased the question correctly. Asymptomatic cases doesn't mean the virus infectivity is less, because they're able to infect other people very easily. So I think the virus is still Tagada virus only. There is no simple virus there. So I am not sure exactly what they are trying to say, but certainly, from my understanding, see, the Tablighi and the ship, the Diamond Princess, were very good because they were in an enclosed space. A lot of people got infected very easily. So it's not, and many of them were asymptomatic.
Okay.
All right.
Okay. Thank you.
Okay,
Thank you.
now time to close. It is 5:30 that we are moving as per the